بسم الله الرحمن الرحيم وأصلي وأسلم وأبارك على سيدي رسول الله. إخوتي أخواتي، السلام عليكم ورحمة الله وبركاته، ويطيب لنا في قرب حلول شهر رمضان المبارك أن نبارك لكم هذه الذكرى المباركة. Dear ladies and gentlemen, it is my honor to introduce to you today the webinar about the pediatric hypertension. This is one of the series of the Shams Club, which used to present every month. Our talk today and speakers, we are having 3 speakers. The first speaker will be Dr. Adil Al-Sinan. He is a senior consultant in pediatrics. For the last 10 years, he was a prior board of directors in Saudi Hypertension Management Society. He will be presented for us an overview about pediatric hypertension. The second speaker will be Dr. Saleh Al-Shurafa, followed by Dr. Mazen Abo Chaaban, and all these 3 will be serving you during the coming 2 hours. I hope we will be all strict to time, and let me announce to you, for all of you who would like to interact or share their queries, comments, and questions, they may do that through the Q&A link, the live event Q&A, which you find it at the top of your screen if you are using a mobile, or on the right side or left side if you are using a desktop screen. You will find it as double bubble. You just go to that and enter your question. Your queries will be considered at the end of the event. Hopefully that we can break some time in between with some queries answered by the speakers. Our first speaker, Dr. Adil Al-Sinan, you are most welcome. May you share your slides and make your mic on. Please share your slides if you don't mind. Yes, go ahead, Adil, you are free to start.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساءكم. We'll talk about pediatric hypertension. Okay. First, to start about an overview about pediatric hypertension is history of hypertension in pediatrics. Before 1977, there was no accepted normative data at all. From 1977 was the first task force report based on 3 sources. So normative data for children had been defined as hypertension more than 95th percentile for age and gender at that time only. After 10 years, in 87, second task force report based on 9 sources, additional data for over 60,000 children. Then increase in third task force update incorporated height in the blood pressure norms. لا أسوي شيء مرة ثانية. لا مبينها الحين الشاشة، هذه الشاشة اللي مبينها. Okay. Then incorporated height in 1996. That is after about 9 years from 87. Then in 2004, that is about 8 years after the 4th working group report, the most major contribution in the era of pediatric hypertension, which is going the normative data till now. Then next speaker, Dr. Saleh, will talk about. Then in 2017, American Academy of Pediatrics published the clinical practice guidelines. So to go with the definition, current definition of hypertension is defined as sustained systolic or diastolic blood pressure more than or equal to 95th centile for age, gender, and height, according to normative data derived from large databases of blood pressure readings obtained in healthy children. As well, we defined normal blood pressure less than 90th centile is the normal one. Elevated blood pressure is more than 90th percentile to less than 95th percentile, or 120 over 80 millimeter mercury to less than 95th percentile, which is lower. Stage 1 hypertension is more than 95th percentile to less than 95th percentile plus 12 millimeter, or 130 over 80 to 139 over 89 millimeter, whichever is lower. Of course, I have to emphasize here, we are in pediatrics in Saudi Arabia up to 14, but this database up to 18 years for full adolescence. Then stage 3 hypertension, more than 95th percentile plus 12 millimeter mercury, or more than 140 over 90 millimeter mercury, whichever is lower. So the epidemiology, to go over hypertension in children said to be rare or very occasional, not important disease in childhood. That's not true. Actually, the demographic data had been changed a lot worldwide, and accordingly, as we will see in a while, the hypertension prevalence changed a lot, especially with the obesity epidemic in worldwide all over the world. Essential hypertension is now thought to be, in some articles, ahead to the renovascular, the most common cause in the past. Most current estimates suggest that the pre-hypertension about 10% and hypertension 4%. Prevalence of hypertension in obese said to be between 11 to 49 to 47%. Childhood hypertension may lead to adult hypertension. Of course, even high blood pressure in childhood could lead to adult hypertension. Prevalence of childhood high blood pressure, including both hypertension and elevated blood pressure. High blood pressure is essentially greater in boys. This is recent data. About 15 to 19 have the propensity to have high blood pressure intermittently, versus girls 7 to 12%. Here, I put it almost in black. Generally, healthy children with primary hypertension do not suffer from cardiovascular endpoints seen in adults. That's really one of the indirect, tricky statement that we should not believe in. Yes, cardiovascular events may not be encountered in pediatrics, but all pediatrics are the population of adulthood. Unless we pick up the disease early, we ameliorate the life and we manage early, as we'll see with the senior colleagues in a while, the patient will go to adulthood with a lot of comorbidities. So children elevated blood pressure are likely to become adulthood, as I said from a while. So early detection is very important, and management to ameliorate the burden of the disease. Now we will go over some studies. Some are local, some international, to have just a message from each one. Here, prevalence of hypertension and obesity, hematuria, just to go fast over it, about 400. This is 2016, published in Saudi Journal of Saudi Medical Journal. Total of 401 children Hypertension was found in 17%, surprisingly, this data, pre-hypertension 4.2%. Obesity was 19.2. So, and there was real abnormalities about hematuria and proteinuria in 10%, hematuria in 17%, and both in 3.1%. So they concluded that we found a positive correlation between the incidence of obesity and hypertension in adolescents. Hematuria, proteinuria were also found to be high screening. So screening and preventive programs are therefore recommended. Here, very fascinating disease. I will go over it to have a message from that one. It's tracking blood pressure in children and adolescents in Germany. Very fascinating, distinguished study published in International Journal of Hypertension 2018. The idea of it, I will see in the next slide. This is the first one. From 3 to 10 years old, about 216 participants in this period. Then they followed them again from 9 to 17, the same participants. So they found from 3 to 10 years that there were, out of those 2016, 7.9% hypertensive. Normotensive are 92. So they followed them. Surprisingly, they found those hypertensive, only 3.1 continued to be hypertensive in the next, let's say, 8 years. Normotensive, 11.6 turned to be hypertensive. So 4.8 from the hypertensive turned to be normotensive, and 80% from the 92 turned to be normal. So it is changeable, it is not fixed. Those, of course, the study is really detailed research one. I just want to convey the message from this one about the changeability of the disease. So the next batch are much less, but still significant, 5 to 6 participants from 11 to, different from those, absolutely, from 11 to 17 years old. 11% found to be hypertensive, almost mimicar to that period, even from the other patch, and 88.8% normotensive. Surprisingly, again, the same occurred. Those hypertensive, 3.8 continued to be hypertensive, and 7 turned to be normotensive. And again here, almost the same, 11 tend to be hypertensive. So what to do, we will see in a while. So here to go for the CPG, the clinical practice guidelines, screening and management, I pointed to, that is for the 2017 American Academy of Pediatrics, just to highlight that it is recommended annual checkup of blood pressure in all children and adolescents more than or equal to 3 years of age for all. But blood pressure should be checked for all children and adolescents more than or equal to 3 years for every health visit. If they are obese, if they are taking medication that increase blood pressure, if they have renal disease, if they have a history of aortic arc obstruction or coarctation or diabetes mellitus. Trained healthcare professionals in office setting should make a diagnosis of hypertension if a child adolescent auscultatory confirmed blood pressure reading more than 95. To be detailed with the next speaker. Again, here there is an indication for blood pressure measurement in less than 3 years. If they are premature, less than 32 weeks, if small for gestational age, if very low birth weight, if have congenital heart disease, renal disease or urologic malformation, including recurrent UTI, hematuria, proteinuria, and family history of congenital renal disease, or have solid organ transplant, malignancy or BMT, that is bone marrow transplant, therapy with meds known to raise blood pressure, other systemic illnesses associated with hypertension like neurofibromatosis and tuberous sclerosis, or an evidence of elevated intracranial pressure. Here now talking to other article about published in Saudi Journal of Kidney Diseases and the Transplant. Actually, it's a sample of preschool children 2 to 6 years all over the country. Great effort, 13 regions of Saudi Arabia, oscillometric devices, about 2,553 Saudi Arabian children aged 2 to 6 years. So we will see in a while where we reached with this data in a graph, the values for each age centile. Recent American had been compared, and this is our importance here to see the comparison. This is the message. This is, for example, systolic for boys, but as well diastolic for boys, systolic for girls, and diastolic for boys, the same idea. They found that, for example, here, 112 in the Saudi population versus 106 in the American population. Here in 3 years, 115 versus 107, and 117 versus 108, 120 versus 109, and 95 here in 6 years, 120 versus 111. So clear variability in all. Of course, they attribute this to variation between different population. But I think there is another contributing issue here. That is the American data is based on non-obese population, and here the whole population. I think this is very important point to pay attention to. But of course, everyone agreed with the of the researcher here that every population should define their own normal standards. That's crucial. So to end here with the study of Schneimer, very interesting one, about primary healthcare, physicians' knowledge and adherence regarding hypertension management. They measure primary healthcare physicians southwest of Saudi Arabia, Jazan region, about cross-sectional investigational data collected from about 316 physicians participated in the investigation, representing 65% of primary health care. Very surprisingly, I will choose what is related to pediatrics more. Recommended daily sodium intake among patients with hypertension, only 34% of the physicians there aware of the importance of it, answered correctly. Effect weight reduction on controlling blood pressure, only 26%. Populations with high salt sensitivity, 31%. Association between BMI and waist circumference and risk hypertension, 36%. Frequency following up hypertension patient, that's scored well, 88%. Normal blood pressure levels among children, only 26% are answered correctly. So report adherence.
Dr. Adil, I hope to stop in 1 minute to conclude.
Okay, thank you. So patients' resting period required before blood pressure measurement, only 29% aware. Sharing lifestyle advice limit salt, 6%. Treatment of hypertension patient with metabolic syndrome, score well, 75%. Interval reassessing patient and controlled blood pressure, 2%. Laboratory investigation, initial evaluation, only 13% aware. So to conclude here that sharing guidelines with all primary healthcare physicians, offering continuous clinical training, encouraging physicians to adhere to guidelines, reducing number of patients seen by physicians likely to enhance their overall knowledge and adherence. Although study is limited to primary healthcare in Jazan, the findings can be generalized and really encouraging study to be done all over Saudi Arabia. Thank you.
Thanks a lot, Dr. Adil. Our next speaker is Dr. Saleh Al-Shurafa. Dr. Saleh Al-Shurafa is a senior pediatric nephrologist in Qatif Central Hospital. He is the Chief Director of the Board of Directors of the Saudi Hypertension Management Society. Dr. Saleh has spent a lot of years in dealing with pediatric hypertension in parallel to the pediatric nephrology interest that he is working on. A lot of experience is behind all the slides that will be presented by Dr. Saleh. Dr. Saleh, the floor is yours. Go ahead.
Thank you very much for this introduction. I am really honored to be with you in this webinar and to share you and maybe to learn from your questions and comments. So feel free at the end of our talks to comment and I will start with the introduction. Hypertension in children is a growing epidemic, as stated by Dr. Adil before me. High blood pressure is estimated to be prevalent in 4.5% of children, roughly. And a recent study by Hansen found that in the United States, healthcare providers fail to diagnose high blood pressure in more than 75% of children. So they are not better than us. Maybe we are a little better. The clinical perspective on blood pressure has changed in recent years. So blood pressure measured regularly and improved knowledge and distribution of blood pressure value during growth. So is hypertension identified in children? This is one of the study that indicated only 0.9% had a diagnosis of hypertension and 3.6% met blood pressure criteria for diagnosis of hypertension. So only 1 out of 4 children with hypertension were identified in medical record as having hypertension. I will skip studies because Dr. Adil have enlightened and explored what's going on regarding detection. So we will go to complexity. Blood pressure in children is a function of age, gender, and height percentile, as stated by my senior colleague, Dr. Adil. And what is normal for one child may be abnormal in other child. And the clinician cannot remember normal blood pressure for the wide range of children observed in their typical primary care setting or hospital setting. So before we start, I think the most important mistakes we do is how to choose the cuff size. And usually many of our colleagues choose cuff size by the name, neonate, small child, children, small adult, adult thigh, etc. But you have to choose according to the measurement of the arm or leg you are using between olecranon and acromion, and the bladder should cover at least 40% to 65% and should circumscribe the arm or at least 80%. Otherwise, it will give you false high readings. And they should be seated and back supported and their feet on the floor with arm resting at heart level. And they have to rest 5 minutes, empty bladder. These standards are written very well in Chapter 1 in our guidelines. So there are, stated by Dr. Adil, casual blood pressure reference data. Most famous is European and United States, which is changed from 2017 to more simplified data, and oscillometric data in US and in States as well in Saudi Arabia. This is classification of blood pressure, which is really good. This is presented by American centiles to make it easy for physicians. They put normal, pre-hypertension, hypertension, etc. So it's very easy to find out, and the ages here. This is very simplified and for screening purpose. The problem is the blood pressure standard for Saudi children and adolescents, as stated by Abdullah Saloom and his group, are different. And they conclude that the blood pressure value in their study differs from those from other studies in developing countries and in the United States, which indicated by Dr. Adil very clearly. So that's why we worked hard in 17,800 kids and develop centile charts. And because family physicians and pediatricians are very familiar of growth charts, it's made as growth charts. So, that's the age and blood pressure, girls and boys. And as you all see, it's increasing gradually with age. That's why you need to plot it in the chart, or you can put it on tables and see. There are also now apps in iPhones and laptops, and the most famous two apps in calculating centiles is from Baylor, which contain the date of birth, measurement, date, and gender, and the unit of measurement, whether it's in centimeter, the height, or in inch, and systolic and diastolic, and then you calculate, and it will give you the centile, and you can plot it whether it's normal or elevated or hypertensive. And there is another app also, which is very similar, coming from UK, which is excellent to use and very quick to use if you don't like to use tables and graphs. So before we proceed, we have to define actually what is normal, what is hypertension. And the normal, as stated in all guidelines, Saudi, Europeans, US, Australians, Brazilians, all agreed to put normal below 90th percentile for age, gender, and height. And then pre-hypertension, this is Saudi guidelines. High normal is European, and elevated, which was changed from pre-hypertensive to elevated, only the name by American, is from 90th percentile to 95th percentile in all. And then above this 95th percentile is the cut-off point to label them as hypertensive, and it's divided to stage 1 and 2 in Saudi guidelines, or grade 1 and 2 in European, or stage 1 and 2 in American, and all agree that it is 95th to 99th percentile plus 5. Only American, they change to 95th plus 12 millimeter, which is almost the same. In here, actually, there are weaknesses in these current definitions, because they all depend on statistical analysis and not target organ damage like our adult colleagues. And these data are based on single blood pressure measurement, but Saudi developed on at least two measurements. And as you see, our population have different centile. So here I just want to put you an example of tables which are very complex. So if we have 12 years old boy and his blood pressure is, for example, 110/80. And first we have to plot which centile he belonged to in his growth. And here is 5th centile. So we go in this and see where is the 5th centile. And then we put on the table to see whether it's normal or high or hypertensive. So this actually age, if they have 90, for example, over 55, normal. The same age with different blood pressure might have either normal or high blood pressure depending on the level and the centile of their growth. There are other methods that we need to document because hypertension is a real problem in pediatrics, and before we go for lab work, which is exhaustive and time-consuming and costly, we have to do ambulatory blood pressure, because blood pressure is having circadian variation. This is during the day, and this is nocturnal dip, and this is morning surge. And in this, as you see here, it's a reverse nocturnal, and in here it is exaggerated surge, and each one might lead you to certain causes. So you have to think and direct your investigation toward the problem. This is actually from one of the campaigns. We found 15% of kids having high blood pressure, like what's presented in the by Dr. Adil, and then we repeat. Probably, I don't know whether they repeat or not. It became 8, then 6% on third repetition, and we have done ambulatory blood pressure on those who agreed to do, and from 6%, 50% of them, they have white coat hypertension. So instead of going to exhaustive lab investigation, I think we need to document by ambulatory blood pressure, especially in pre-hypertension and stage 1 hypertension. There are datas, because we don't have our centile. We usually use European data for ambulatory blood pressure, and this is how it looks. And you plot and you see whether the child is hypertensive or not. Home blood pressure measurement are really good in adults. In pediatrics, they are not meant for diagnosis because no published reference data for that, but it's good for follow-up of blood pressure during the treatment. So how do we classify our blood pressure readings? They are either normal or hypertensive, and the cutoff point is 95th percentile for age, gender, and height. If in the clinic it is low, and by ambulatory it is, normal, then we call it true normal tension. If it is in the clinic is high, but by ambulatory is normal, we call it white coat, which is really common, as you have seen. And if it is in the clinic normal, but it is high in ambulatory, we call it masked hypertension, and that have, an effect on organs, so it can lead to target organ damage. And if both are high, we call it sustained hypertension. This is how it looks in ambulatory. This is from actual patients. It will give you systolic with average, standard deviation, minimum, maximum, and dipping, and diastolic, and pulse pressure, and heart rate, and you will see during sleep how is the depth, and you can then plot it in the charts and see whether the child is really hypertensive or not. This is Muhammad, who is having very severe hypertension, and we did ambulatory blood pressure. Actually, first of all, I asked my resident whether the child is hypertensive or not, and the blood pressure was 129 over 89, and the child is 8 years. So immediately said, oh, I forget to plot it in centile. If it exceeds 120, it is high, regardless of the centile. You plot the centile only to classify the blood pressure. So then what we did, we actually did ambulatory blood pressure, and it tended to be normal. So what might give you hypertensive in clinic visit, he might be normal because of white coat hypertension. And these are his readings. Obesity, as you see here, the more obese, more prevalence of hypertension. So we have systolic blood pressure and diastolic in the screen for each BMI percentile category. And this is again an area of research in blood pressure measurement in our Arab world. This is one of the obese kids because of high variability, hypertension. We reduce his weight just by lifestyle and tend to be normotensive and no need for treatment. This is another one who have severe hypertension. When we reduce, he will become normotensive, and then he will become obese. He's very hypertensive. Smoking in adolescent is very important cause of high variability blood pressure. So first, lifestyle, weight reduction. So if you have, measured the blood pressure and it is above 90th percentile, then you remeasure twice and you take the average. If it's normal, it's normal. And then if the average is more than 90th percentile, you can repeat by scaltatory method and you remeasure it twice, or you can proceed to ambulatory blood pressure monitoring if you have it at your institute. So how frequent we...
Dear Dr. Saleh, 1 minute left.
Okay.
Sorry to disturb you.
So we need to do annual blood pressure monitoring, but in every health counter if they have any one of these causes. And there are special circumstances which is below, we can measure below 3 years old if they have one of these: prematurity, congenital heart disease, renal disease, transplants. So in each child you will have 4 clinical questions. Whether does my patient have hypertension, and if yes, why? So you have to go to see whether obesity, family history, evidence of secondaries, etc., especially in young kids. Then if there is any evidence of target organ damage, which will be presented by my colleague, Professor Mazen, and if there are any other modifiable risk factors like diabetes. So this is how you go and evaluate the patient. Once patient have diagnosis confirmed, you determine underlying cause and you assess comorbidity, and you go into details in family history, physical examination, and lab. So I will just conclude here that the detection and treatment of hypertension is important to prevent long-term cerebrovascular and cardiovascular complication, and we have to do aggressive attempt to identify and treat hypertension to eliminate the risk of target organ damage, and to eliminate the overdiagnosis and overtreatment in these patients. And in last 35 years, ambulatory blood pressure monitoring has emerged to a variable mechanism for assessing the clinician to decide whether these kids are real hypertensive and to assess treatment decisions. Clinicians should become familiar with these, and nurses should be familiar with standard blood pressure measurement. Compared with casual blood pressure measurement, ambulatory blood pressure measurement has proved superior in predicting either target organ damage or morbid events. Thank you very much.
Thanks a lot, dear Dr. Saleh. Great presentations. I hope we will enjoy as well your presentation at the end of this webinar. Our next speaker, I'm honored to introduce him, Dr. Mazen Abo Chaaban. He is a pediatric nephrologist. He worked in Germany in the early 80s. In the early 90s, he has worked in UAE, in Dubai. And currently he is in the Emirates Specialty Hospital as a consultant pediatric nephrologist. Dr. Mazen was the former president of the Pan-Arab Pediatric Nephrology Association, PAPNA. I missed to inform that you as well, that Dr. Saleh was one of the former presidents as well. Dr. Abo Chaaban, it's my pleasure to introduce you. Please share up your slides. They are ready, and the platform is yours, please.
Assalamu alaikum wa rahmatullah. Allow me to thank you all, and to thank the Saudi Hypertension Society for inviting me for this really nice webinar, from which myself I have learned a lot, to be with my colleagues and to share the information and the knowledge with the colleagues. As a whole, it is really my pleasure and honor to be with you today. I'll be presenting as organized with Dr. Saleh, Barakallah fi, the part of the hypertension in children, because the other colleagues have covered already the most important issue.
May I ask you to share your slide, Dr.
Yeah, it is shared now. It is shared. Yeah.
Oh yeah, that's great.
It is shared.
Okay. Yeah, just make it. Yeah, it is already there. Just make it presenters mode. Yeah, that's fine. Please go ahead. Yeah. Sorry to disturb you.
My part was actually to speak about the clinical evaluation, and I think that was a very good choice from Dr. Saleh to be able to cover the whole topic about hypertension in pediatrics and adolescents. I had a great help from the book of the society, actually, to be able to concise myself and to be able to summarize the things which I wanted to summarize, because that, this part, it was, inside my slides, but it was not as a separate entity. Anyhow, the clinical evaluation aim 4 parts or 4 branches. First of all, when a patient comes, the most important issue for us is to establish the diagnosis of hypertension. If you are in doubt that this child might be having hypertension, and of course to be able to differentiate between the primary and the secondary hypertension. In case also, to detect any risk factors of cardiovascular disease or any target organ damage or associated clinical condition. These are all factors which should be tackled from couple of clinical evaluation, like the history, like the physical examination, like the blood pressure measurement, and like the basic investigation. Most important of which actually is the history, where from the history is taken properly and is taken with care, it will be actually a great help for the examiner to be able to diagnose whether there are risk cardiovascular factors, whether there is history of current symptoms suggestive of cardiovascular, whether there is symptoms suggestive of secondary hypertension, how the lifestyle of my patient, whether he's alcoholic, if he's a teenager, whether he's a smoker, whether he has taken before antihypertensive drugs, how is his medical history, if she's a girl, actually not a boy, about oral contraceptive, non-steroidal anti-inflammatory, or taking steroid for any of the reasons, and at the end, the family history and whether there is any associated disease in the family, like diabetes mellitus, cardiac disease, stroke, or renal disease, which can all help me in understanding my patient much more and in proceeding with my patient to the second step, of course. The physical examination, the physical examination, as all of our pediatrician and ourselves know, that we always stress on the weight, the height, the BMI, and the waist circumference of the patient, because it is of a great value and will give us a great information about our patient, whether he's obese, whether he's underweight, whether he's suffering from certain problems, whether he's marasmic. The second thing, in the examination, the physical examination, the chest examination for rails, abdominal examination for organomegaly, which can be easily missed if it's not examined, a central nervous system, as well as a cardiac, if there is any arrhythmias, any murmur. Retinal examination, of course, this is very helpful in case of long-standing hypertension, which can cause retinal changes and vascular retinal changes, which can be seen from the retinal examination by when the pupils are dilated from experience ophthalmologist. Vascular should be examined as well as to rule out any absent arterial pulse or carotid bruit or radiofemoral delay. These are all the most important things in the evaluation of the patient. Most of the patients who do have or who get in doubt of having hypertension, they will ask, are you going to do for me investigation? I'm worried, I have so and so, I need to know myself and my body inside. Don't forget, and this is one of the most important for our pediatrician as well for ourselves, that urine analysis is one of the most important tests we are doing to our patients. The children, it is a little bit difficult to collect urine, but it should be one and the first factor in examining a patient who might be having a problem, because the urine, as you know, it is the mirror which will reflect what is inside the body to the outside. And the urine itself is great to tell us about whether there is any protein which can tell us that there is a renal damage, any glucose which can indicate whether there is diabetes or not, any blood cast or any blood red cells in it which can indicate any glomerular injury there. A blood chemistry which can give a very good idea about the renal function. A lipid profile which can give an idea about the patient and how his even it can reflect his family history if he's a child and he's having high lipids, hemoglobin and hematocrit, of course, to rule out any anemia or any other associated hemoglobinosis which might be there and can affect our evaluation for the blood pressure. One of the important things, of course, in case we want to go a little bit deeper, then ECG is one part of the examination, as stated in the Saudi instructions and recommendations. The thyroid stimulating hormone, the free T4, they are optional, of course, if you are in doubt, or if you during your examination you find that the thyroid is enlarged, or you find that there is a strong family history of thyroid problems in the families of your patient, then the TSH should be done actually, and I would recommend it strongly. The chest X-ray, if during the examination and auscultation you find anything doubtful. Abdominal sonography, if there is any protein or blood, to rule out any urologies, to rule out any long-standing kidney disease, which can be seen from the abdominal sonography and the renal sonography. The echocardiogram, of course, can give a very good idea about the cardiac muscles, about the valves, about everything which is helpful in the diagnosis of hypertension in children. I think with these slides, I have covered the clinical evaluation, which actually is supposed to be covered in, I mean, from me, in my second part of the talk. I don't know if the moderator would like me to continue.
Yes.
I'm
Please go ahead, Doctor. Please go ahead.
Go ahead. Yeah, then I mean the second part after the evaluation, of course, which will be, I mean, our target, how to manage. What is the management? I mean, I have diagnosed from all what the colleagues have said, and from what I have done, from the examination, from the investigation, from the ECG, from the chest X-ray, from the echocardiogram, I know that my patient is hypertensive, and I should proceed with the management of my patient. The management, of course, it depends on too many factors, whether the hypertension is of a mild degree, and the definitions have been said by my previous colleagues, barakallah fihum, and it is known now what is the pre-hypertensive, hypertensive, and advanced hypertension. So the management depends whether it is a mild or it is a severe hypertension, what I'm dealing with, and whether there is any underlying cause or the presence of cardiovascular disease or the presence of risk factors from my history and from my examination. The severe hypertension, like what the colleagues have said, is most likely to be a secondary hypertension, and it's having a secondary underlying cause, and the treatment of the underlying cause, I mean, is a major part, and it should be our target to be able to help the patient to resolve from his hypertension. We always tend, I mean, before we start, I mean, it's very easy to write medication, but our target is always, especially in the pediatric age group, is to stress on the non-pharmacological measures, should be given the priority as an initial therapy alone or as combined with other medications. I mean, we start of course with the alone, and we see how it is and whether the patient is in need. When we can start the non-pharmacological measures, in case in these conditions, actually, which I'm going to state, like essential hypertension, high normal blood pressure, which is between the 90 and the 95, severe hypertension, but in complement with other drug therapy, in weight reduction for obesity, if the obesity is related to the hypertension, irregular exercise and restriction of sedentary activity, dietary modification, including salt restriction, and I think, and everybody of us know that the Arabic as a whole, the Arabic children, they love salt, and they put salt as if they are putting sugar on their tea, and that's why, I mean, this is one of the important parts which should be stressed on when we are dealing with hypertension in children age group. Of course, I mean, if our patient is smoking, or he's alcoholic, or he is drinking too much coffee or tea, I mean, which is caffeine, all of these things should be reduced, which, I mean, all combined can decrease the risk of cardiovascular disease and risk factors. The one of the most important things, and everybody of us had the experience with that, if the patient is obese and you reduce the weight of your patient, you have solved more than 70 to 80% of your problem, because the weight reduction leads to decrease in the systolic and diastolic blood pressure and reduces the risk for cardiovascular disease. Affects positively the serum lipid profile, and when the lipid profile is affected and goes back to normal, it will diminish the effect of dietary salt on the blood pressure itself. The second factor, actually, other than the weight reduction, is the physical fitness. The blood pressure is directly related, actually, to the degree of the physical fitness, and when combined with weight reduction, the effect on the blood pressure regulation is more pronounced. It has a beneficial effect on other risk factors like hyperlipidemia. The dietary intervention, of course, dietary intervention or dietary approach, like one of them is the DASH system, have proven to be beneficial not only in adult but in adult and in children and adolescents as well. Reduction of the sodium, of course, increase in fresh fruits and vegetable consumption, low-fat dairy products, encourage a nutrient and balanced diet. These all things which will lead actually to helping of our patient if he is really living non-healthy life, and he is a patient of fast food, and the patient who is he never walked for 1 kilo by itself. All these measures will be of great help and can solve the problem. If we come to the pharmacological therapy, which is of course an important part of the treatment of hypertension in the patients who do not respond only to the physiological measures, we know that the mean blood pressure is equal to cardiac output multiplied by the peripheral resistance. So any pharmacological therapy should target either the cardiac output or the peripheral resistance, or sometimes in some of the medication it will target both of them. Actually, most of the antihypertensive agents other than the diuretics act on the blood pressure by lowering the peripheral resistance. The diuretics, as you know, they decrease the blood volume load, and in other way they are affecting the blood pressure to reduce the blood pressure. The peripheral resistance is affected by the renin-angiotensin-aldosterone system as well as by the sympathetic nervous system. And as you have seen, actually, all these which mentioned, you will be seeing now that the medications are targeting the things which we have mentioned here, actually. And it is actually of value when it is really targeted, and you know where you are starting and why you are starting and which medication you are choosing. The goal of a treatment and the choice of a drug, the goal of the treatment is the reduction of the blood pressure to below 95th percentile. The choice of the antihypertensive medication should be guided by the underlying principal mechanism of hypertension, whether it is renin-mediated versus the volume-mediated, the ease of administration of the drug. Don't forget that you are dealing with pediatric patients, and the ease of administration of the drug will be very helpful to the child as well as to the one who's going to give the medication, which is mostly the mother or the father. The severity and nature of the drug side effects and the cost of the long-term therapy, which is very important. And some of the patients, they stop the medication because the drug is too expensive, and sometimes insurance will cover, otherwise in other insurance they don't cover. The antihypertensive drug should actually have the following criteria whenever you start the antihypertensive medication. You should not, start from the highest dose. You should start from a lower dose and then go stepwise up until you reach to the dose which can affect the blood pressure of your patient and bring it to the normal level. Least toxic drug should be prescribed first because it is of less harm to the patient. The maximum recommended dose of one drug before adding another. Go stepwise until the drug have reached to a level where it can decrease, but without reaching to the maximum, below the maximum. And if it is not enough, and depending again on the etiology of the blood pressure, then you can add another medication. When combined drug therapy is used, the drug should have different sites or mode of action to attain an additional effect. The antihypertensive drug should be individualized depending on the severity of the hypertension, the degree of response, the occurrence of side effects, and the patient's medical history, of course. The first drug, which is used for the last years and years, is the diuretics, of course, and still it is in sometimes the first drug of a choice, depending as well on the underlying cause, whether it is a volume overload or whether it is other reasons. Then the diuretics can sometimes in teenagers can be started. They are still being used as first line. The exact mode of action is not well known. enhance excretion of sodium and water, decrease the intravascular volume and the cardiac output. The side effects of the diuretics is the hypokalemia, hyperuricemia, hyperglycemia, evaluation of serum cholesterol, elevation of serum cholesterol and serum triglyceride, and decrease HDL, especially with thiazide. The second category of antihypertensive medication is the beta blockers, and they are very well known to everybody of us: the propranolol, the atenolol, the metoprolol, and the bisoprolol, and the other groups of the drug. They are being widely used in the initial therapy of essential hypertension, and still they are used as initial. Again, I will mention depending on the etiology. They can be used alone or in combination of other. Their mode of action is mediated by reduction in the heart rate and cardiac output, and a blockage of the release of the renin through the kidneys, and which will end in I'm getting lost, sorry now. Which will end actually in reaching our goal, and in response to the adrenal stimuli, anyhow, which is anyhow it will decrease at the end. It will decrease our aim, which is the hypertension. It will be decreased. The beta blocker, the side effects is hyperglycemia, bronchospasm, hypertriglyceridemia, sleep disturbance, and bradycardia in some individuals, and that's why the dose as well as the medication should be chosen and individualized, as we have mentioned, according to the need of our patient. The contraindication of the beta blockers is patients with asthma or obstructive airway disease, severe peripheral vascular disease, bradycardia, second, third degree heart block, depression, Reynolds phenomena, insulin-dependent diabetes, mask symptoms, because they will lead to mask symptoms, or they will mask the symptoms of hypoglycemia. Alpha-beta blocking agent, and especially labetalol, which was really a blessing, and we are using it mainly in emergencies and hypertension emergencies in kids, where it can be given as IV, as intravenous, and the dose can be adjusted in a very nice way according to the need and according to the drop of the blood pressure. Side effects of the labetalol, the first side effects is the postural hypotension. Otherwise, it is a very safe medication and can be used in the pediatric age group. The fourth or fifth group of antihypertensive medication is the angiotensin converting enzymes inhibitor, and they are as well very known and beloved from us, from all nephrologists, like the captopril, the enalapril, lisinopril, fosinopril, which are actually very well known and very good used, I mean, in the pediatric age group. They block the biotransformation of angiotensin 1 to angiotensin 2 and subsequently prevent vasoconstriction, stimulation of the aldosterone synthesis and renal sodium and water retention. They are of great benefit in high renin hypertension. They are now widely administered due to their ability to reduce the protein and to preserve renal function, as well as their positive benefit on the cardiac function. And in the proteinuria or nephrotic syndrome with long-standing proteinuria, most of us are getting the use of the angiotensin converting enzyme inhibitors to be able to decrease the intracapsular pressure and decrease the oozing of the protein through the glomeruli. They lack adverse lipid and the glycemic effect of other agents. Their side effects, of course, is bone marrow depression, taste disturbance, angioneuritic edema, skin rash, hyperkalemia, a dry hacking cough, increased risk of to the fetus, especially in the pregnant women. We should be very careful because it may cause fetal anomalies and may lead to abortions, neonatal anuria, up to renal failure and death, acute renal failure in sick hypertensive in neonates. So we should be very careful when these medications should not be given to pregnant women. The one which is taking the priorities now is the angiotensin receptor blocking, which the abbreviation ARBs. They are losartan, valsartan, irbesartan. They are actually now widely used and better used than before in the pediatric age group, and they are approved from the FDA to be used in the pediatric age group, and they have found that they have limited and very few side effects, which led to its vast use in the pediatric age group. They inhibit the renin-angiotensin system by selectively blocking the 81 subtypes of angiotensin II receptors, preserving the beneficial effect of the angiotensin II at the 82 receptors. Hacking cough and angiolytic edema are not seen. They are now FDA approved, as I have mentioned, and they have proven to be effective in pediatric age group. The contraindication of them in patients with bilateral renovascular hypertension, in patients with volume depletion, or in pregnancy, because they may lead to adverse side effects on the fetus. The other antihypertensive medication is the calcium channel blocker. Calcium channel blockers, they lead to decrease the peripheral resistance by making the relaxation of the smooth muscles of the vessels, by inhibiting the influx of the calcium, calcium, causing the inhibition of the tone and the relaxing of the smooth muscles, and decreasing the peripheral resistance. They moderately increase sodium excretion and thus enhance fluid loss. They are thus the good choice in patients who cannot follow dietary salt restriction. And the long-acting ones, the long-acting ones, they are more effective than the short-acting ones for different aspects and different reasons. They don't cause hyperlipidemia or insulin resistance. They are indicated in patients with asthma because they don't affect the bronchial tree and they don't cause any bronchospasm. The side effects of them, of course, if they are given, and we used to give it, I have a paper which is published, we used to give in the neonates and in pediatric age group sublingual nifedipine, which has proven to be very effective. I have never faced any hypotension, although hypotension can be one of the side effects if it is given sublingually. Second and third degree of heart block, you should be very careful, and congestive heart failure and with systemic dysfunction, you should be as well very careful. The hydralazine, minoxidil, diazoxide, and sodium nitroprusside, they are kept for use in hypertensive emergencies in pediatric age group, and they should be very well monitored because of their serious side effects, like reflex tachycardia, increased renin output, sodium and water retention, positive ANA test, and lupus-like symptoms, excessive hair growth around the face and forehead in case of minoxidil, and it is used as shampoo and it's used as treatment of hair loss. The alpha-adrenergic blocking agent, which is also now rarely used in pediatric age group, and that's why I will not go through it, like the prazosin and the doxazocine. We will go the sympathetic blockers like the clonidine, alpha-methyl-dopa. I had good experience with the clonidine patches, and I have used them for a very long period of time, and they were very effective in the teenagers and the pediatric age group. Their side effects is the dry mouth, the drowsiness and sedation, rebound hypertension following sudden discontinuation, local skin irritation at the site of the patch application, and can cause as well bradycardia. I will conclude actually the two topics which I wanted to speak about, and the take-home message, which is I believe it should be actually stressed on. Blood pressure checking should be part of the routine examination in the pediatric age group. Early diagnosis and intervention is essential to avoid organ damage and organ damage. Efforts to prevent and to control childhood obesity should be taken and stressed on. Awareness of the side effects of the antihypertensive agent can assure their proper monitoring. and they will listen also their side effects. Patients, parents understanding of the nature of the hypertension and its outcome can help a lot the way how to decrease the side effects of the hypertension. And patients and parents should be educated, and finally they should know all the side effects and how to deal with the side effects to be able to avoid them and to understand the nature of the medication more. Thank you very much for listening. Thank you for giving me the chance to present my talk.
Thanks a lot, dear Dr. Mazen. I wonder if your time allows you for 10 minutes of presentation of Dr. Saleh and have the discussion thereafter, or shall we proceed with the discussion further?
I mean, I can listen to Dr. Saleh. I mean, I will not miss Dr. Saleh.
Okay, that's great.
Dr. Saleh,
that's great.
If you don't mind, of course.
Yes, please. So, Dr. Saleh, the floor is yours. Dr. Saleh will introduce now the Saudi Hypertension Management Society's guideline for pediatric high blood pressure. Dr. Saleh, please.
Thank you very much, Dr. Badr, and I would like to thank my senior colleague, whom I learned logistics from him, Dr. Mazen Abo Chaaban, who helped me and make my life so easy when I was very young, introducing me to European societies and to Arab world society. And I will not forget his stance behind me. Thank you very much, Dr. Mazen. So I would like, and now he is making it so smooth. He talked about almost all my talk. I will just go, and talk about, Shams guidelines, which is now, the first version. This is the first, and there are 3 more versions. We are in the 4th version, which is 2018. So we develop, with years, and we improve. Actually, our scope of guidelines, we made subcommittees charged with developing and updating evidence-based clinical practice guidelines. We provide recommendations on diagnosis and evaluation and management of hypertension, and we aimed at practicing a clinician, seeing patients in outpatient and inpatient. This is the level of evidence we were using, like any maybe other guideline, and we have 30 chapters written. Most of chapters contain pediatrics as well as adult, but there is one specific chapter for children, and 4 different chapters indicated adults and pediatrics very clearly, and there are appendices at the end for kids, including graphs, blood pressure graphs, and table. So these guidelines are updated in 2018 with a broad group of professionals, including physicians, pharmacists, dietitians, guideline development experts, and methodologists, with the 26 contributors and steering committee. And the physicians belong to many disciplines, actually, whom they are working in Saudi Arabia. And this is clearly shown in contributors if you go to page 6 in our guideline. In general, the evidence analysis used were published, evidence-based guidelines and reviews. So we review almost all literatures until 2017, and we publish at 2018. And in addition, members of the group were asked to identify any more recent publication just before publishing it. The section guideline allotted to reviewers, and then steering committees, and then editing, etc. So it goes to process of development, And the editorial subgroup developed final consensus statements that considers the clinical evidence and applicability, cost effectiveness, cultural values, and they actually give us very hard time, and the head of steering committee is the one who is moderating our session. So, first of all, before we proceed, we have to define the hypertension as we stated it before, and it is almost similar to other guidelines available around the world. So, and then we wrote the statements and who should have blood pressure measured. So our recommendation that all children 3 years and above should have it annually, and children who are more or equal to 3 years at every healthcare if they are encountering conditions or risk factors or medications increasing the risk of hypertension. And the children of 3 years or more should have blood pressure measured under special circumstances. And we put a chapter of measurement technique, which is appropriate cuff, need more than one measurement, etc. And then we go and stated that accurate measurement of blood pressure in children, and we give statements and the grading for each statements reviewed by evidence-based, specialists. So, for example, abnormal oscillometric values should be confirmed with auscultation, and we grade it as C. I think Canadians are grading it like us. Americans maybe grade D. Maybe their review was a little older than us because they publish their guidelines at 2017 and we publish it at 2018. And then we recommend ambulatory blood pressure measurement in children. And we recommend blood pressure measured at these conditions for children below 3 years. This is exactly what's written in the guidelines. And the guidelines contain many tables and some, algorithms. And this includes the history and examination, specific examination, and the most likely causes of secondary hypertension for neonate, for example, coarctation of aorta, renal artery thromboembolism, renal artery stenosis, and congenital renal anomalies below 6 years, renal parenchymal disease, and 6 to 10 years, renal parenchymal disease, and for adolescents, primary hypertension if they are above 10 years, and renal parenchymal disease. So what was the goal in our guidelines? To achieve blood pressure that is reducing risk for target organ damage and reducing risk for hypertension related cardiovascular disease in adulthood. And we achieve an optimal blood pressure level if we get below 90th percentile. In adolescents in European, Dr. Mazen, they are putting 95th percentile. This is the difference. So here we put management of pre-hypertensives by lifestyle. If still elevated, we check upper and lower extremity. We repeat lifestyle counseling and we recheck in 6 months. If it's still elevated over 12 months, then we do ambulatory blood pressure and we conduct diagnostic evaluation. And if people are doing it, they consider subspecialty referral. If blood pressure normalized, then we go to annual screening. If it's still up, we do pharmacological treatment. And this is a stage 1. If they are asymptomatic, only lifestyle. If they have stage 1 and still hypertensive, lower and upper extremities, and we consider nutrition and weight management if they are overweight or obese. If unchanged over 3 visits, then we do ambulatory blood pressure. This is the difference, only 3 visits, and there is almost 1 year. And we consider subspecialty referral. In stage 2, we check upper and lower extremity blood pressure. We start lifestyle and we repeat blood pressure within a week. If they are asymptomatic, they are symptomatic, we admit and we manage them as hypertensive emergency. And then if repeat unchanged, then diagnostic evaluation within a week, including ambulatory blood pressure. We start our treatment and we refer if indicated to subspecialty services. If symptomatic or blood pressure is above 30 millimeter, above 95th percentile, then we have to put in emergency room or admit and manage by antihypertensives. So lifestyles, the diet is very important, as stated by my friend, Dr. Mazen, and physical activity, weight loss, stress reduction, and these are the, the recommendations. So if these are failed, or if we have symptomatic hypertension or secondary hypertension or stage 2, or we have evidence of target organ damage or diabetes, whether it's type 1 or in adolescents type 2, CKD, chronic kidney disease, then pharmacotherapy is indicated. Or if there is persistent hypertension despite non-pharmacological measures in stage 1, then pharmacotherapy is indicated. So how do we manage? Usually these are the treatment with mechanism. I like to start with ACE inhibitors, but if I am suspecting renal artery stenosis, I usually go for calcium channel antagonists, and most of now recommendations, although the grade D moving to grade C, are doing the same, and these interrupted lines not recommended to combine. These lines you can combine therapy if you maximize your dosing. Of course, the choice is very important. You see this, boy, whom we could not, control his hypertension until we put him on minoxidil, and you just imagine, and then, alhamdulillah, we are achieving the goal, and we remove minoxidil. So how we intervene? As I stated, we start with ACE or ARBs or long-acting calcium channel blocker or thiazide diuretics in some cases. And ACE or ARBs if the patient having chronic kidney disease, diabetes, or proteinuria. And we usually start with single medication at low end of dosing, and we increase every 2 to 4 weeks until blood pressure is controlled. If not controlled, then we add second agent and titrate. This is in usual setting and not in ICU setting. In ICU setting, we might go very quickly, maximizing doses and adding lines of medications because of target organ damage, which is very quick there. This is exactly how it looks, antihypertensive for emergencies and urgencies. These are Saudi FDA, approved, and these are the doses, maximum and minimum, and the route you can start, and you can review it from guidelines, and you can download it either from our web or you can Google it and you download it. These are the neonates with the medications and initial dosings for hypertension management. This is usually in OPD settings with dosing. So how do we monitor it? Lifestyle changes, 3 to 6 months. If then pharmacological intervention, we check every 4 to 6 weeks for adjustment And if we achieve our goal, we check every 3 to 4 months. Home blood pressure measurement recommended for follow-up and not for diagnosis. We recheck ambulatory blood pressure measurement, once it's indicated, or annually, especially in chronic kidney disease patients, and we assess for adherence and side effects. So what is our target? In general, below 90th for age, gender, height. In chronic kidney disease, below 75th percentile, and if they are proteinuric, we are going very aggressive to reduce it below 50th percentile or unless symptomatic of hypotension. And we do 24 hours ambulatory. For resistant, these are the maneuvers, but I'm not going to go over it. And long-term follow-up is clearly written in our guidelines, and that is dependent on underlying cause of hypertension, with further investigations may be indicated to monitor the success of surgical intervention like renal artery stenosis and etc. So this is the ambulatory blood pressure, and this is how we manage.
1 minute, please.
I will, yes, don't worry. I will end up with this very important slides indicating how you manage. In normal, you recheck next visit or annually. You encourage healthy lifestyle. In pre-hypertension, you recheck in 6 months, and you do weight management if overweight. You increase physical activity and diet management, and stage 1, weight management, physical activity should be encouraged, and if no improvement, then you add pharmacotherapy, or if there is target organ damage, you add pharmacotherapy. Stage 2, you add pharmacotherapy with these, and you go for investigation, and you refer to within a week and immediately to, if he is symptomatic, to emergency treatment. And this is how we classify and the frequency, etc. So how do we implement? These are the guidelines to implement our guidelines, but we need to improve. We need to develop, for example, non-mercury sphygmomanometer and oscillometers, which are easy to use and maybe to give us the centiles. We need our own reference values in Saudi population, especially in obese patients, and we need to increase knowledge in the use of out-office blood pressure measurements, and we need to collect information about early organ damage to refine risk stratification and use of this information to set, and we need to conduct controlled studies, multi-institutional, to have bigger data, so we will have large and long-term randomized therapeutic trials using onset of organ damage to obtain information about when to initiate antihypertensive drugs treatment and blood pressure goals. The message I want to give you from this quick talk: we have to measure blood pressure annually if the age is 3 years and above, unless otherwise indicated, like what we wrote before, and we have to have cuff sizes different, and we don't take the name of the cuff, we take measurements. Blood pressure classification is based on age, height, and gender, and generally we start with lifestyle, medication if lifestyle fail, or symptomatic or associated with target organ damage, or associated with chronic kidney disease or diabetes, and you have to refer to subspecialists as needed. I really thank you, and I am honored actually to share you this quick view of our guideline. Thank you very much.
Thanks a lot, dear Dr. Saleh. It is time now for discussion. I hope that all speakers are around. Dr. Mazen, are you around? Dr. Adil, Dr. Saleh. Okay, we'll start. We'll start the first question will be directed to Dr. Saleh. Dr. Saleh, in a busy clinic, blood pressure measurement may be really a hard duty to be fulfilled, especially if you would like to take it more than once and whether they are reliable or not. Really, from your real practice, how to overcome such a problem? Will it be with multiple visits, using special measurements, special devices? Please. Dr. Saleh, make your mic unmute, please.
Thank you, Dr. Badr. What we usually do in the first visit, initially we calm kids outside the clinic, and we measure by oscillometric device, Dynamaps, quickly. If it is normal, then we don't remeasure. If it is high, we let the child settle and do it again. If it is difficult, we ask them to come in another visit. So kids will get used to see us, and he will not have stress because of these white coat. And we don't usually go for a table, complex table. We see the level and we plot it in the graphs I've shown you, because the graphs which is developed, the Saudi graphs, which is developed in here nationwide, are very easy because it only correlate with age. If it is showing that the child is hypertensive, then we go to tables, and because it's really time consuming. If the child is not calm or crying, and then we just calm the child. We don't take it until he comes for next visit, or unless it is really indicated.
Thanks a lot, Dr. Saleh. The second question for Dr. Adil, is there any genetic differences between different societies in the Middle East, or at least in the Gulf? Do we mean that those who are in the Eastern province, they are genetically different in their predisposition to develop pediatric high blood pressure than those who are, for example, in the Western coast, genetic-wise?
The question for international, yes, there is genetic variabilities. It's well known for the Afro-American and Hispanics are more predisposed for high blood pressure. But for Arabian Peninsula, I'm not aware of local study dissecting this or answering this question.
Thanks a lot. The third, still for back to Dr. Saleh. Dr. Saleh, there is a small question. Do they need 3 measurements in a visit, or do we need 1 measurement in 3 visits to have an average?
Thank you for this question. Actually, what we do 1 measurement. If the blood pressure is high, then we repeat another one after 3 to 5 minutes with following the standards of blood pressure measurement. And if it is still high, at the end of the visit of the kid, we take the 3rd one and we average them. If the child is not settling we can do one at a time, and we do it in next 2 visits if the high value is pre-hypertension or stage 1 only without evidence of target organ damage. But if it is stage 2, no, we have to do it. This is how we do it in the clinic. So
sorry to interrupt you, Dr. Saleh.
We do one normal, that's it. We don't repeat 2 or 3. High, if it is not very high, then we might repeat it if the child is calm. If not, then we might ask them to come again. Thank you.
Thanks, Dr. Saleh. What about pre-hypertension levels? Do we need really as well to repeat or to have more further workup for them?
As I stated in the guideline, if we have pre-hypertension, then what we do, we first give them lifestyle modification, healthy lifestyle, and we ask them to come in 6 months for a repetition. Then, if they still have pre-hypertension in the other 6 months, we might go for ambulatory to classify whether it is real pre-hypertension or there is an element of white coat causing this high pre-hypertension levels. This is how we do it.
Thanks a lot. The last few questions for Dr. Mazen. Dr. Mazen, this is telling whether for pre-hypertension or those who are having high blood pressure, whether it is stage 1 or stage 2, what is the minimum clinical evaluation needed, and who should do it? Whether it will be the general physician, whether it is pediatrician or family physician, or it must be in a specialized clinic? Dr. Mazen. It seems that we are missing Dr. Mazen, so I'll re-forward my this question to Dr. Saleh.
Yeah, thank you very much. I think if the child having stage 1 hypertension, then the family physician can proceed with lifestyle, weight management, and simple investigation that's including renal profile and maybe asking for an ultrasound. He can ask if he is not sure that the child is normal, he can ask for an echo, because the first target organ damage is the left ventricular hypertrophy. If he did these 3 basics, urine analysis and culture, that's all. And this can be done either by a family physician or pediatrician seeing this patient. But if it is stage 2 hypertension, then I recommend referring this child to specialized clinicians or interested clinician treating hypertension to to go deep into science and to direct their workup toward the specific diagnosis, and at the same time to start the treatment.
There is one more issue. Do we measure renin and aldosterone in evaluating hypertension in kids? And is it a must?
No. Renin and aldosterone as a basic, it's a big no. It's not indicated, number 1, and number 2, it's not available everywhere. Unless you think of specific diagnosis, then you don't have to really measure these. And to direct your diagnosis, the ambulatory blood pressure and the simple investigations might direct you to a specific cause. For example, if you do ambulatory and it is, reverse nocturnal death, and you do an ultrasound and there is a difference in the kidney size between right and left of more than 1 centimeter, that might indicate renal artery stenosis. So instead of going to renin and aldosterone, which is exhaustive, you can go directly to MRA, magnetic resonance angiography, which is now available in almost all institutions, secondary institutions and tertiary care institutions, or if not available, CT angiography, which is can delineate with the high confidence if there is renal artery stenosis, or if there are if you think that some of the causes might be diagnosed only by these labs, you can go and do it. Otherwise, you don't go and do this lab investigation routinely.
Thanks a lot. Thanks a lot. Yes. The other question still for Dr. Saleh. Do you advise combination therapy from the start in stage 2 hypertension or very high BP? And as far we are in the starting the medications, is it okay to start medication in pre-hypertension state?
I can divide your question to two.
Yes, please.
If you have stage 2 hypertension, which is asymptomatic, so there is no hypertensive emergency, you start hand in hand with labs, but by monotherapy, unless there is a compelling indication to start combined therapy. For example, if he has edema and hypertensive, because of, for example, he's having diabetes, diabetic nephropathy, or nephritis, or you can start with diuretics and one of the medications. This is otherwise you start with monotherapy, you start with the lowest dose possible, and you upgrade it and you maximize. So you either get side effects and you stop there, you start another medication, or you reach the maximum dose without controlling the blood pressure and you go for another medication. What is your next question? I don't know.
We are having still a few questions, Dr. Saleh.
Yes.
What is the what is the first line medications in black children?
Black children. Black kids. Kids are different from adults. So what is the first line medication in adults maybe is little different, but in kids, we are all, as I stated, the first line either by ACE or by calcium channel blocker. These are the two usual first line medication. And
so it is almost the same as the adult hypertensive patients.
Yes.
Okay. For Dr. Adil, there is one query about screening hypertension. Is it a must for all those individuals presenting to the clinic, whether it is a general clinic coming for a disease patient child, or it is for coming to the well baby clinic? Is it a must to have blood pressure screened over there?
Checking the blood pressure, as I stated in details, more than 3 years, it's routinely annually recommended, and for every visit, for about 6 categories, I stated it clearly. That is those using drugs, that raise blood pressure, those with renal impairment, with diabetes, and with family history of renal disease. less than 3 years, as you said, in well baby clinic, yes, it is included for all newborns, prematures, less than 32 weeks, and small for gestational age, other complicated neonatal problems, including as well congenital heart disease.
So it is annual unless the patient is having a risk to develop high blood pressure, then it would be in every visit.
Yes.
Okay, that's great. Back to Dr. Saleh. Here is a case in otherwise healthy girl, 10 years old, with episodes of high BP and headache, while the renal function is normal, including the ultrasound. There is no evidence of any endocrine involvement, and the MRI for brain is normal. What is your suggestion for such a case? Is there any further workup need to be done, or no, we just observe the patient, or no, we may go for treatment, whether it is pharma or non-pharmacological? Dr. Saleh.
Yeah, you need to check and be sure that this child first is hypertensive, and then you need to confirm the class of hypertension, and you go for non-pharmacological therapy, which is indicated for all kids, even the healthy kids, to promote healthy lifestyle. And you follow. If still high and the it's not resolving with the healthy lifestyle, then you go for ambulatory blood pressure to see what kind of hypertension, whether it's with high variability, like in obese or smokers, whether there is a stressful conditions, or acts which lead to hypertension, like iPads and iPhones and games. And if whether this girl is having exaggerated morning surge to indicate some of causes of hypertension, like for example Wagner's, polyarteritis nodosus, etc. And then if you document that she is really hypertensive and not responding to the lifestyle, then you might go for pharmacotherapy.
Okay, coming to the last question, when to refer a high BP child, and to whom?
Yes, you refer, the child if that child is having stage 2 hypertension. If you want to do ambulatory blood pressure, if the child is symptomatic, or if the child having comorbid conditions like chronic kidney disease or diabetes, or if that child having evidence of target organ damage. In that case, you refer to either interested pediatrician treating hypertension, or pediatric nephrologist. So if in your area you have the pediatric nephrologist, you can refer directly to pediatric nephrologist. If not, then you might refer to pediatrician. Now, the reason I'm saying pediatric nephrologist and not pediatric cardiologist, for one reason. Pediatric cardiology, unless they have congenital heart disease, or having an evidence of coarctation, like if you do blood pressure in upper and lower limb and there is a difference, Otherwise, it's not indicated to refer to pediatric cardiologist. So the answer is refer to expert pediatrician, whether he is general pediatrician or pediatric nephrologist.
Okay, thanks a lot, Dr. Saleh. Thanks for your contribution. Thanks a lot, Dr. Adil. Thanks again for your contribution. And thanks for Dr. Mazen for his contribution. Thanks for all attendees for their valuable time and sharing with us this series of Shams Club. Let me remind you, please evaluate this session to get your certificate, which is shown now in the announcement, and the link is over there. And hopefully to meet you on 24 Chaaban, which match 6 April, Ramadan fasting multidisciplinary discussion. Hopefully we will enjoy your contribution all. Thanks for all, and مع السلامة وفي حفظ الرحمن وآخر دعوانا أن الحمد لله رب العالمين.
Thank you.